这边还有2个位置，如果要上来的人可以上。住院医师有在吗？没有，住院医师都不在。他们其他校外的住院医师没有在就对了。哦，好。So the first case is a 56-year-old female who had a past history of left breast cancer. This is her pleural effusion specimen. So on low power, we can appreciate that they were scanned by the tight cluster of cells. So these are the cells that we need to go to higher power to confirm. So this is what we suspect to have the second population. So when we go to high power, this is very obvious that we do have very big nucleus with prominent polymorphism. Some arranged in like a kidney shape, some is rounded. And pay attention to the chromatin pattern. The chromatin pattern is abnormal. It shows that small, like a vesicular pattern. Additionally, the nucleus has a very interesting shape, which is also highly abnormal. So this is consistent with metastatic carcinoma. And the arrangement showing a glandular feature. Some of the cell is eccentric. So this is consistent with adenocarcinoma and consistent with the patient's past history of an invasive ductal breast cancer. So these clusters are quite scattered in the background. The key point is to just identify under the low power, and then we go to higher power to check. Yeah, so here again, it's very weird looking cells with highly prominent nucleoli. So this is consistent with metastasis adenocarcinoma. Because it is a breast cancer, we will call this positive for carcinoma. So this is a 41-year-old female, so very young, and this is her pleural effusion specimen. So just on low power, we do have more these tight clusters of cells. So the specimen is easier to screen comparing to the prior case. So we just go to higher power. And again, very tight cluster. So the chromatin pattern is pretty abnormal, irregular. Instead of just a single prominent nucleoli, the cell do show like maybe more than one nucleoli somewhere. But the polymorphism is striking, and you can appreciate that the nuclear membrane is highly irregular. We do see some notches here and there. The shape is also very different. So this is consistent with metastatic adenocarcinoma. The most common primary for this is coming from the lung. So the morphological pattern is consistent with lung adenocarcinoma. The patient already sent specimen before, and we proved that it is TTF1 positive. So we don't need to do it again. So sometimes the clinician send multiple specimens, just want to release the symptom of pleural effusion, or just try to acquire more specimen that is suitable for molecular testing. So in this cell block preparation, we can also identify the tumor cell. So the cell block might be able to do additional molecular testing. So the next patient is coming from the same patient, but it is a pericardial effusion specimen. So pericardial effusion is not a very common specimen, but when we receive it, the positive rate is much higher than the usual effusion from the pleural cavity. So in this specimen, we see even more tumor cells. So with a very similar morphology, because this is from the same patient. So most of the cells are metastatic adenocarcinoma. So now you can appreciate enlarged nucleus, very prominent nucleoli, eccentric arrangement, and the three-dimensional tight cluster. So for the cell block, we also have a lot of these tumor cells inside the cell blocks. So this is a good specimen for molecular testing. So let's move to some finding the aspiration. So first, we take a look of the EUS guided FNA for the pancreatic lesion. So for EUS guided FNA, the needle will go through the intestinal mucosa, intestinal wall, and then into the structure beneath it. So here we can appreciate flattened honeycombing arrangement of cells in a large sheet. And scatteredly, you can find there are some empty spaces in between. These are actually the mucin cap. So when you see this, you know that we are in the duodenum, and these are scattered goblet cells in the duodenal mucosa. So this is a benign duodenal mucosa that is commonly seen in EUS guided aspiration, and so this is from the normal mucosa contamination. So the diagnostic criteria is very similar. We just need to identify these highly atypical tight cluster with pleomorphism. So these looks like adenocarcinoma. Let's see if we can find some more. So the good thing about the EUS guided aspiration is that you always had a nice reference benign looking cells in the background. So these, with this tall columnar shape, this is the duodenal mucosa that you can appreciate that we are having these picky friends type of arrangement, very regular. The size of the nucleus is also very regular, and the interspace between them are also regular. Right next to it, so you can appreciate that the size of the nucleus is markedly increased. Additionally, just within one cluster of the cells, you can appreciate we do have smaller cells, we have much bigger cells, so it demonstrates striking pleomorphism. So these type of pleomorphism, we call these 1 to 4. In one cluster, the cell variation is more than 4 times, and this is diagnostic for adenocarcinoma. Additionally, you can appreciate the arrangement is also highly irregular. Some overlap and some with a very big gap. So this is also disorganization, which also diagnostic for adenocarcinoma. So for this specimen, it is positive for adenocarcinoma. So next is also a EUS guided specimen. So in this specimen, we have palsy cellularity, very, very scant cells. So occasionally, we will see the situation like this because we know pancreatic cancer is usually highly desmoplastic, which means that it has a lot of fibrotic stroma, and sometimes it is not easy to get all the cells out of this stroma. So we only have a very scattered cluster of cells, but just within these cluster of cells, so you can appreciate similar feature that we just discussed. We do see some nucleus overlap, some with a bigger gap, some smaller nucleus right next to it, bigger nucleus. So these looks abnormal. These looks like an adenocarcinoma. So we just need to strolling around to see whether we have better cells. So these actually looks a bit benign because it is rounded, uniform, and the space between them is regular. So these actually looks more like a benign cluster of cells. So not every cluster of cells demonstrate uh, features of adenocarcinoma. We just need to look around. So most of the cells are actually benign looking. So we only have this one cluster of cells showing prominent feature of adenocarcinoma. So we go to the direct smear. So these all looks benign. So these are likely just a pancreatic acinar structure. So we only have one class of cell looks highly atypical. And in this situation, we can use indeterminate diagnosis such as suspicious for adenocarcinoma. But the patient had the biopsy confirmed to be adenocarcinoma. So we will call this adenocarcinoma. So next, this is the parotid aspiration. So on low power, we notice that the background is relatively clean. We do not see any mucin. We do not see any necrotic debris. It is very cellular, and majority of the cells do show like abundant, dense, granular cytoplasm. So these looks like oncocytes. So we have tight aggregates of oncocytes, and pay attention to the architectural pattern that we do have nice organization of small nesting as well as the trabecular pattern, and these are all in very tight like a cohesive cluster. We do not see like individual cells or discohesiveness. And because of these architectural pattern and the bland appearance of these oncocytic cells, this is consistent with a benign oncocytoma. So because of these high cellularity, we want to do a cell block to see if we can identify some more cells in the cell block. Unfortunately, the cell block is negative for any cells. So because of this morphology, we still will send these out as benign neoplasm compatible with oncocytoma, nodular oncocytic hyperplasia. So the next specimen is coming from a 22-year-old male. So the clinician labeled the aspiration site is submandibular mass. So when the clinician says submandibular mass, it can mean many things. It can mean it is coming from submandibular gland. It can mean that it is coming from a lymph node of a submandibular region. It can also mean that it may be coming from the soft tissue of submandibular lesion. So when you see submandibular mass, it does not necessarily mean that the lesion was coming from the salivary gland. So on low power, we have a lot of background material. Yeah, looks kind of complicated, a little bit busy. We do see some cells looks like lymphocytes. So these looks like it is coming from a lymphoid structure. Maybe it's coming from the lymph node. We actually do not appreciate many cells of epithelial origin. We do not see a lot of like aggregates, tight aggregates of the cells. However, some structure is relatively unusual is that we start to notice there are some very dense stroma and with a very close relationship with some bland looking short spindle cells. So this is actually quite abundant throughout the entire specimen. Some of the spindle cell, we do notice they are intranucleus pseudo inclusion. I'm not so sure if you can see on the television. There is a very good pseudo inclusion over here. So it seems to have like a lymphocytic background, but we do have a lot of these fragments of stroma along with some like a small bland looking stromal cells. Some with even a more like a palisading appearance. Yeah, so I go to the clinical like information. I check the image. It is a 23-year-old male, so very young, but the lesion is actually 4 centimeter. And the clinician suspect that although he aspirate from the submandibular lesion, but he suspect the lesion is actually originated from the base of the oral cavity. So initially, his clinical impression is that it is a mass lesion coming from the sublingual gland. So sublingual gland is relatively, it's a very small structure, but the lesion is 4 centimeters. So I call him, I ask him that what happened when he do the aspiration. And he said that the patient immediately like a response says there is a numbness feeling. Yeah, so these all like match with each other. So these is actually like most likely to be a benign schwannoma originated from the lingual nerve. Okay. And for the Schwann cell, occasionally you can appreciate intranucleus pseudo inclusion. So for this particular lesion, I think the stroma is much denser than what we used to see in a schwannoma, because usually it's more loose with like a fibrillary like edges. Here we do see some fibrillary edges, but it's just denser than it used to be. However, it is 4 centimeters. So realize that it might be in the patient for a while. So these might be a old like a schwannoma with more dense like a stroma. So the stroma actually pushing the spindle cell away. But here we do appreciate the palisading type of pattern. So because he's a young patient, there is a chance that it might be like a syndromic from the like a neurofibromatosis patient. So let's move to some pap smears. So the first one, 46-year-old female. So she is young, but when you take a look of these pap smear, we do not see superficial cells. So there must be something happened to this patient. So this is endocervical cells, benign, like a nicely like a honeycombing arrangement. So it looks like an atrophic cervix without estrogen stimulation. So when we go to the history, the patient is a patient of breast cancer. So she's under tamoxifen, like a hormone therapy, to inhibit the estrogen. So this is the effect of hormone therapy. So when we go to higher power of these very tight, like a dark cluster, it is a hyperchromatic Rowley group. And we notice that the cells are actually enlarged comparing to the adjacent inflammatory cells. Additionally, you can appreciate these cells does show pleomorphism, overlapping, and coarse chromatin. So coarse chromatin, similar to the squamous cell carcinoma, is relatively common in the breast ductal carcinoma. So here we do identify tight cluster with like a glandular type of arrangement, but with quite hyperchromatic and irregular coarse chromatin, some with prominent nucleoli. These actually looks like breast cancer. So the cells are actually throughout the entire smear, accompanied with some like a bloody discharge. So here again, very tight cluster, highly like a hyperchromatic, and you see some coarse chromatin with a squamoid-like appearance. This is actually very typical for breast ductal carcinoma. So throughout the smear, this is benign endocervical gland. This seems to be carcinoma. And we have a lot of these highly atypical cellular cluster. So when the smear presented with this type of pattern, which means that these tumor cells are directly sampled from the cervix, which means that the patient had a direct, like an invasive, like a metastatic lesion in the endocervix or in the cervix. So that's why we can see the cells are so well preserved and in a very large fragments. So we just want to make sure that this is actually coming from the breast instead of like SCC, something else. So we do a GATA3 on the other like a direct smear. So you can appreciate that they are negative like intermediate cells or endocervical cells, but these larger cells are positive for GATA3, suggest that they are metastases instead of the primary lesion. So this is consistent with breast cancer with direct metastatic disease in the cervix, and we sampled it in our pap smear. So the patient also received cervical biopsy and confirmed they are metastatic breast cancer in the cervix. So the next patient is 28-year-old who had a past history of vagina wart. So she had a condyloma and received like a laser treatment, and this is her screening pap smear. So we can identify a few very scattered like a superficial cells with a little bit like a hyperchromatic nucleus, a little bit irregular arrangement, some coilocytic features, and these are all kind of scanned. So because the lesion is likely in the vagina, so for a cervical smear, we expect that we might probably see only a few of these type of cells. But because of the history, we would still call these ascus. Although they are very scant cells, but these does show features of HPV infection, so we will call these ascus. So next is a 37-year-old female. And this is one of the scenario that is kind of difficult that we will use sometime in determinant diagnosis. So 32-year-old, we have nice superficial cell and less intermediate cell compatible with the patient's age. We have endocervical cells. So here we have these tall columnar cells with apical mucin. So these are Piggy Friends arrangement. There we see these endocervical cell from the side. And if we see from the top, we will see these honeycombing type of arrangement. So we have superficial cell, intermediate cells, a little bit inflammation in the background, some endocervical cells, which means that T-zone is sampled. And then we have a very tight, like a cluster of cells. Looks like this. So it does show a little bit like a honeycombing type of arrangement with a luminal border. However, the hyperchromasia is very striking. And overlapping hyperchromasia, some irregularity. So this is relatively abnormal. And the arrangement seems to be glandular, but the chromatin pattern looks like it is more consistent with squamous cell lesion. So looks like a high seal. And there might be a mitosis over here. So just looking at this cluster, this can be a high CO with a glandular involvement. However, it's kind of strange that we take a look of the background and along this smearing direction, we do not see any of them. So on the second slide from the same patient, we also identify one just single cluster of very tightly aggregate of cells with sort of like a similar appearance. And without like a prominent single cell cohesiveness, just a little bit around this lesion. So I think this case is suspicious for high CO. We just don't see enough, and we don't see like individual cells that we will be more confidently call these high COs. So for this case, I'm going to call these ascus high, cannot exclude high CO. And it does show some like arrangement of glandular cells. So high CO with glandular arrangement sometimes is not easy to interpret. Sometimes you would call this AGC instead of a typical squamous cell. So this is why we are going to call these ascus. So the next specimen also very unusual. I don't know how to do with this case with the TBS terminology. So I decided not to use it. So this is coming from a 56-year-old female. She only just visited our hospital once. So this is from her recent visit in our gynecology department with symptoms of abdominal pain for a few days and irregular mens. And she visited the other like a community hospital and was referred to our hospital. So she only visited us once. In these smears, we do not see intermediate cells, superficial cells at all. We only see blood and very tight aggregates of these like a dark cellular cluster looks like hyperchromatic crowded group. And that's it. No squamous cell at all. So this is not a typical screening scenario. This is not for like a precursor cervical cancer screen. With this type of bloody smear, commonly we will encounter with an invasive lesion. So this is actually directly sampled from an invasive lesion. So when we go to higher power, I think these cells does show some unusual morphology. First of all, it does not show typical arrangement of epithelial cluster, which usually you will see like for squamous cell, you can see like a wrapping around the cluster. But you start to see that these atypical cell with very high NC ratio, but chromatin pattern relatively pale, and some of these like a spindle-shaped cells. So to me, I think it actually looks more like a sarcoma instead of it is a true epithelial origin lesion. So here we have some squamous cells, intermediate cells, very scant, and then we take a look of these. These are just small round cell with very high NC ratio and highly irregular like a nuclear shape, a lot of spindle. However, it still maintains a relatively like a monotonous uniform type of pattern. So yeah, I really don't know what it is. I'm thinking that could it be the endometrial stromal sarcoma actually. So it doesn't look like a typical for any like common tumor that we will see in the cervix. So I go back to the clinician's notes. She do have some testing for certain tumor marker. The SEC was low. She only had a very slight elevation of CA125. By pelvic examination, the clinician identified a mass lesion protruding from the cervix, but we do not see any like a good amount of epithelial cells in the background, and it all looks like a feature of small round cell, tight cluster. So I don't know what to do with this one. So I call these suspicious for malignancy, and I told that there were presence of a typical round cells in a bloody background, and it's in favor of uncommon neoplasm and suggests biopsy. Yeah, so this is most likely an invasive lesion. I think I can just directly call these like malignant, but because I don't know what it is, I don't know what malignancy it is, so I decided just to use suspicious for this one. So I cannot use any like a TBS terminology for the case because this is not a screening case. Yeah, recently I find our gynecology, young gynecology, they are really don't know what to do, how to do the smear. They cannot do the smear right. So this is coming from a 28-year-old female. So relatively scant, quite some inflammation, a lot of superficial cells, and in the background, a lot of bacteria. So we do have clue cells. So the background is relatively paucicellular, a lot of inflammation. And they were like a very, very scant cells with degeneration. I don't really know what exactly it is. I'm not so sure whether this is squamous or this is like a glandular cell because of this chorioresis type of pattern. Could it be just degeneration? And in the background, there are a lot of like a bacteria and the debris type of material. Yeah, so it doesn't look very much like there is like a definite lesion. Here we do see some actinomyces. So that's it, but the patient do have HPV testing. So it turned out to be positive for 16. So she is positive for HPV 16. So here again, this looks like a repair type of change with intermediate cell, a lot of cellular depth, like a process, cytoplasmic process, arranging a tight aggregate sheets with a streaming pattern. And the nuclear feature is, if you take a look of the chromatin, it's actually regular, delicate, regular. So it doesn't necessarily looks like it has some issue with these cells. So that's it. So it looks like a reactive smear to me, but the clinician go ahead to do a biopsy. And you show some like invasive lesion over here, right? And there seems to be like a falling apart high seal over here. We do not see this type of cell at all in our smear, not at all. So they just do a very poor smear, and we cannot identify the lesion at all, but I just call these Ascus high. Although I do not see any lesion that I'm like with my criteria is definite for Ascus high. But these are, I mean, if you call these Ascus high, you would call every specimen Ascus high. So that's very, very difficult. So I guess that people say the sensitivity of HPV is higher, which is true, but they also identify cases with only infection without precursor lesion. So sometimes you still need the pap smear to further triage the management of the patient, because not every patient should go to colposcopy. But if they don't do the smear well, we won't be able to identify the lesion, we won't be able to call it. So we have a lot of discrepancy recently, and I think it's primarily because they didn't do the smear right. If they get the area, the foci, they smear it and they put it on the slides, we will be able to identify it. But for this case, it's very difficult. With this correlation, I really don't find any cells looks like what we see in the biopsy. It is an invasive lesion now. She's only 22. 28. Yeah, among the youngest SCC that I've ever seen. Okay, so that's for all the case today. Thank you.
Sure.
Sure.